Thank you for coming to this session. We're really excited to have an education session of the Congress. I'd love to see it as a half day or a whole day because, if you think about it, we're all educators. And sometimes we think that education is just about training veterinary students to become veterinarians, to become veterinary surgeons. But every day, when you're out in your practice work, you're training farmers or you're training producers. There's also the whole education of vets themselves and continuing education as well. So education crosses everything that we do. And I'm very excited to be able to introduce you to Professor Peter Constable, or Dean Peter Constable. He's my boss, so be nice to him, okay? So he's my boss. If there's one word to for me to sum up Peter, when I think of great teachers, it's those teachers that create uncertainty, not because they're not a good teacher, but they start you off with a question. And if you look at Peter's history, Peter did a PhD, he did all of his training at the Ohio State University, but if you look at his research, he's really challenged dogmas. And if you read most of his papers, he's said, this is what everybody thinks, but is that true? And he continues to do that. That's kind of his driver, is questioning dogmas, making you think about why do I believe what I believe? Why do I practice what I practice? So he creates uncertainty, and then he answers the question and gives new direction within that. Peter's had a number of leadership positions. He's now dean at the University of Illinois College of Veterinary Medicine. He's had over 200 scientific publications, 30 book chapters, and has worked all over the world. So it's great to to welcome him here as our keynote speaker for the education session. So please join me in welcoming.
Thank you very much, Dr. Aldrich, for that very generous introduction. And I do hope to get some people thinking here with the next 40 minutes, and we'll see whether I'm successful in that. So the education of food supply veterinarians. I like the term food supply because if you ask yourself why does society fund colleges of veterinary medicine, it's fundamentally to ensure and maintain a safe food supply. What we do on the small animal side and so on is all very nice, but we've got to deliver on the need to meet society's needs for a safe food supply. So this gets to what is an appropriate curriculum for food supply veterinarians. And you can talk about categories, and I like categories such as knowledge, skills, and professional characteristics. Some people call that aptitudes. But I think it's very helpful to when we start constructing a curriculum and thinking how we're going to deliver it, that sometimes we're delivering knowledge, sometimes we're delivering skills, sometimes we're trying to grow great professionals. And then how do we do that? I'll have some thoughts about delivery method and organizational structure. And for those of you that know me, hopefully I've got some evidence for those thoughts. And then we'll get a little bit into postgraduate education, which direction I see that going. So whenever we're talking about education as a dean, I've got to keep asking myself, we've got to be effective and we've got to be efficient. Now, there's lots of different ways to give a curriculum. A lot of them are effective, but they're too expensive. They take too much resources. They might burn out faculty. We might not have the space to actually deliver that curriculum. So I think this balance between effective and efficient is something that we always have to focus on. And the goal, and I have to keep reminding our faculty of this, our goal is day one competency. The goal should not be resident level board certification. And a lot of our faculty, particularly in the clinics, unfortunately set that bar too high because we're all excited about our own little discipline and we all want the students to be just like us and we convey that excitement, but we're setting the bar too high. So here's an interesting point. Is orthopedic surgery for small animal, is that core? Do students really know how to do a total hip in small animal? So you can start asking questions like this. But then it gets into critical issues for food animal is what is day one competency? And the AVMA, the American Veterinary Medical Association, has asked us to deliver day one competent veterinarians, but they haven't actually gone out and defined what those competencies are, and we'll discuss that a little bit. So when we get to curriculum, to me, when I get asked for resource allocation, I start to think, is this a must-have or is it a nice-to-have? And that's a very useful question to keep asking ourselves. And then that sort of gets down to core versus elective curriculum. So if we talk about individual attributes expected of graduating veterinarians, if you look in the handout and the proceedings, I've got a lot of what I regard as the seminal publications on educating particularly food animal veterinarians. And there's a couple of figures that didn't actually make it into this document because I ignored the page limit and wrote a little bit too much. So I'm not the only person who have done that before. So when we talk about knowledge, to me, that's not just fact retrieval, it's also understanding and ability to apply that to new areas. But I think a really good phrase is walking around. So I expect a competent entry-level food animal practitioner to know that the normal rumen contraction rate is 3 per 2 minutes, and you've got to auscultate for 2 minutes. If you auscultate for 1 minute, you're doing substandard clinical exam. So that's walking around knowledge. But do they need to be able to tell me what is the typical somatic cell count from a quarter due to E. coli and what is different to Staph aureus? Maybe not, but they need to know how to find and access that information very, very quickly. So we need to give them the skills to access knowledge and be able to discern what is an accurate piece of knowledge that they can get. But there is walking around knowledge that they must have. Technical skills. One of the really disappointments of some of the surveys that we've done is what is valued about entry-level veterinarians is that they can do some skills. They can give an IV, they can pull a calf, they can identify pregnancy. And what's disappointing about that is that's getting down to the apprenticeship model or a vocational school, which is not a professional school. But there is no doubt that's what the marketplace expects. And certainly our clients, if you're not competent at these routine skills, they're going to not have confidence in you for some of the more higher level issues. And then there's these professional characteristics, and everyone wants to jam this into our current veterinary curriculum. We don't have space. So the big debate is, do we demand that our students have these before they start the veterinary curriculum, or do we try and sneak them into the curriculum so it's not a specific course on these issues like teamwork and professionalism and ethics and scientific method, so that we sort of integrate it and infiltrate it right throughout the whole curriculum as we go. So if you sort of look at the way curriculum is identified around the world, and I've been fortunate enough to visit a number of countries and looked at the way veterinary education is delivered around the world, the OIE is taking a leadership role in developing countries to at least make certain that they've got appropriate food security, so that the food that is developed in that country is appropriately safe to consume. So this would be regarded as the minimum. What is interesting is I don't think one veterinary curriculum in North America actually meets these criteria, particularly to deal with public health. In North America, the veterinary profession walked away a fair bit from public health 40 years ago, not so much in Europe, and we're trying to capture that back in that meantime. So I'm going to talk a little bit about the United States because there's a number of colleges there. The system has been developed for many, many years. In many respects, it's mature. It's been discussed. It's been debated. And it is, to some regard, the de facto world standard for curriculum, albeit without a public health emphasis. So one document to actually to examine that is called the American Veterinary Medical Association Council of Education document. It has a number of standards, and I particularly want to draw your attention to number 7. It's quite riveting reading if you want something to put you to sleep at night. But the things that are interesting is they say that new graduates must have basic scientific knowledge, skills, and values. So that sort of gets to the 3 areas that I wanted to focus on. But they don't really define what is basic. And to me, this is a critical issue for us. And that each school must develop measures to say, yes, we're delivering on that. Again, they're basically running a big experiment out at about 40 or 50 colleges of veterinary medicine around the world to come up with some best practices. What I think will happen in 5 or 10 years, they're going to start being prescriptive. And they're going to say, you have to actually prove that your graduates are competent in all of these particular knowledge areas and skill sets. But they're not there right now. I'm just going to pick out some examples. Sorry, I've gone a little bit too far forward. If you look here, if we look at anesthesia and pain management, we've got to be competent in that, basic surgery skills and basic medicine skills. So let's talk about that. So what are the best basic medicine, surgery and anesthesia skills? I'll submit that it varies absolutely from country to country depending on what your industry is. But the University of Illinois has really, in my mind, been the world leader in defining this. And it started with Ann Johnson, one of our leading small animal orthopedic surgeons, who was also served as president of the American College of Veterinary Surgery, extensively published. But this was one of the seminal papers that actually went out and asked the question, well, at least what do veterinarians in North America in small animal practice do, as sort of a starting point for defining what actually they should be competent in. So we liked that paper so much, Dawn Morn and myself and others at the University of Illinois decided we needed to do that for food animal. And it was amazing to us, this paper I think was published in 2001, that this hadn't been done as far as we could tell anywhere in the globe, at least defining what do the average practitioner do on a day-to-day basis. And there were some real surprises. So I'd suggest that this might be helpful for you to look at your curriculum to see whether you're actually teaching things that at least veterinarians in North America are doing commonly. Obviously, that's going to be different in your country. So why is this an important question? Well, 80% of our students enter clinical practice. We've obviously got limited lecture time and laboratory time, and that's expensive to deliver. So we want to make certain it's efficient and effective. Some of these labs are very expensive. In fact, I just looked at our course budgets, and our bovine surgery course is probably the most expensive course we deliver on a per student basis. That doesn't mean we shouldn't do it, but it's expensive. And then there really wasn't much data out there to say which we should really be looking at. So some of the other arguments is there's a perception that there's a changing role in bovine practitioner. Herds are getting bigger. There's global issues. There's world epidemics. There's greater emphasis on biosecurity, on production values and so on. And there's subspecialization amongst the veterinary profession, particularly in ruminants. So here's just an example. This is a dairy that's about 2 hours away from the University of Illinois, 36,000 milking cows. And Dr. Aldrich has been able to do some wonderful things accessing that. But this is certainly a different industry than it is in some countries and certainly what it was 100 years ago. So we did a survey. This is a long time ago, needs to be repeated, but I don't know if the results will be much different. And I would argue this needs to be done pretty much in every country to find out what are your veterinarians in practice doing and make certain your curriculum is delivering on that. What is incredible on this is 60% response rate to a male survey. That is unheard of. If you get into survey literature, that tells me that practitioners were very passionate about this subject. This took 55 minutes to fill in the survey. People who started it, they all finished it. So this is something that they felt we weren't delivering a product that they needed out in the marketplace. And we did a standard questionnaire. We had a lot of questions, but we asked both proficiency and frequency, but surprisingly, actually it wasn't surprising, things that practitioners did frequently, they expected the graduates to be proficient in, so I'm only going to present the frequency data. And we subdivided this into surgery, anesthesia, individual animal, and production medicine, because at this point there was also a big push from production medicine that's saying that you didn't need to do individual animal teaching anymore. That was old school, not needed. That was certainly not my impression, because if you're going to prevent milk fever, you need to be able to diagnose milk fever, you need to be able to treat milk fever, otherwise the farmer's going to have no confidence in your ability to control that. And reproductive. We asked them based on the small animal study, and this has been replicated in every other design that's been done like this for different species, as to how frequent do you do it. So 0 is never, and a 4 is all the time. So obviously most things are going to be somewhere between 0 and in the 3s. The skills and frequency scores ranged from about 0.1, so there was really nothing that got an average of 0, but pretty close to 0. So we probably shouldn't be teaching that in the core curriculum. If practitioners are never doing this, that's really a resident specialization thing to things that are being done at least once a week. At least 40, about a quarter of them, had scores that said they were performed at least once a month. I would argue that's probably an entry-level competency, something you're going to see every month that you're out there practicing. And I would argue they probably should be in the core curriculum. So we'll just go through some of these, and some were really surprising to me. So injections, oral medication, pregnancy diagnosis, venipuncture, treatment of pneumonia, at least done every week. So our students have to be very competent on that. Don't think that surprises anyone. Dystocia is there. I will submit that most veterinary curriculum do a poor job on teaching correction of dystocia, particularly with actually doing it. You can have dead calves in sort of haptic things and so on, but actually alive dystocia, I think most of us aren't doing the job that we need to do on that. Treatment of diarrhea, but at least it was interesting, cardiac auscultation, there was a little bit of stethoscope work on there, also with auscultation of lungs. Okay. So some more that are at least done once a month, so auscultation of GI tract, and then into a little bit higher level synthesis stuff after all of these skills. So this was a little bit disappointing, but this is entry level, so what that says is as we as veterinarians proceed in our career, we can start doing a little bit more of these advanced skills. And then treatment of metritis, treatment of mastitis, probably wouldn't surprise anyone here. Here are some that really surprised you. Ruminocentesis, no. Ration formulation, starting to get into expert. So should we be even spending much time on teaching that at a veterinary school? And you know, I'm a cardiovascular physiologist, but we shouldn't be teaching them ECGs because you don't have one out in the farm. All you need to be able to detect on practice is the heart rhythm regular or irregular. Likewise with CSF aspiration. So this is quite interesting, and we use this to change our curriculum because we were spending some time on some of these things and not enough time on the more important things. What about some of the surgical skills? Big surprise, castration was the most commonly performed surgery in North America. I would not have expected anyone to predict that. Every week, veterinarians in North America doing castration. So we went from 10 minutes on castration to almost 2 hours on castration lectures to make certain that that was covered extensively. Epidural anesthesia, very commonly used, dehorning, tattooing. We didn't have tattooing in our curriculum at all. So veterinarians are out there doing that. Foot lesions, wound management, this was a real surprise out of the small animal work as well. How do you handle an abscess? Wasn't in our curriculum. Very common thing, so it needs to be in our curriculum. This is probably a North American bias here with ear implanting, which is very much liked in North America. So much so that they've got an antibiotic that you inject in the ear because people are injecting into ears. Vaginal prolapse repair. So some that aren't used very often, fracture casting. So we had lectures in our curriculum on how to do a fracture. Well, maybe it's not that important. But joint lavage. So these are never to rarely done. Umbilical resection. We love talking about that because that's a really fun surgery. Not that commonly done by typical practitioners. Cryonecrosis or cryosurgery. I prefer cryonecrosis because it's really fairly broad. Some of these other techniques, particularly inhalation anesthesia, the skill set is not that required for entry level. Now this paper I think was fairly influential. It certainly changed our curriculum. It changed the curriculum at some other colleges where I've talked extensively to people delivering the veterinary curriculum. And then it was repeated at Kansas State, pretty much exactly the same results. And then a focused area was done on theriogenology using the same approach. And they got pretty much the same results right here, is that you've got to be able to diagnose pregnancy, you've got to be able to handle a dystocia, and do a breeding soundness exam, particularly on males. and then cesarean section. And then this is another area this was actually, I think, the third most common surgery done. I didn't show that previously on our survey, which is cesarean section. It's very hard to deliver that as a skill set. So we're working at the University of Illinois to expose our students to cesarean sections, but that's also a challenging one to deliver in a curriculum. All right, so the next question is, okay, now we've got some, at least in North America, some idea about what should be in the core curriculum to get a competent entry-level veterinarian. Well, how do you define competency? And the argument a little bit is it's like great art. I know it when I see it, but then that's a little bit personal. But most people can agree on what is great art and what is not. So some of the techniques for doing that is OSCEs. We've got a very mature OSCE process at University of Illinois. I think it's working very, very well, but it's expensive. And it's consuming a lot of time to do that. But that certainly is good literature that that's a nice way to go. There are other techniques, such as a clinical evaluation exercise. That's probably not as strong as OSCEs. And then what a lot of schools do is a direct observation with a little student log. So they have a little book. They do a venipuncture that's observed by someone like a house officer or a faculty member, and they initial the book and say, yes, you can do a venipuncture. So we need more work on which is actually the best way to document that you have these skills. A lot of opinions out there, very little hard data on which is the best way of doing it. I can tell you OSCEs are expensive. And we did a lot of this while I was previously at Purdue, and that's fairly low cost until the student runs their logbook through the washing machine, and then it becomes very high cost because they've got no documentation. So there are other ways of doing this. So Bonnie Rush at K-State has got a computerized way of doing that seems to help with some of the paperwork. But the issues are really efficient. What is efficient for use of faculty, house officer time, and to actually do it? And then how do we differentiate completion from competency? And then often we do this the first week on the rotation rather than the third or fourth week, and they're going to be hopefully a lot better on the fourth week. So we might not be evaluating it when they've actually really mastered the technique. Here's an interesting question. How many times do you have to do something to become competent? So is it like riding a bike? Once you've got that for life? Or do your skills degrade over time? So if you look at that, you can maybe measure time to completion and define, yes, that procedure was done appropriately and successfully. And we've been using that as a metric, and I think that's useful when you've got small replicates. Really a better way is complication rate. But to do this properly, you need about 400 replicates, which is not going to be possible for our educational purposes. So let's look at some interesting data that's out there. Surprisingly enough, very little written on this on the human side. If you delve into the human medical literature, very little. But look at this. This is time to take in some manual anesthesia skills for their residents. And they get really excited if they can actually intubate a human. So these are residents, and they're arguing that it takes them 20 to 40 intubations before they have an 80% completion rate. Well, that's not very impressive to me. But they're arguing that there are some differences in the rate of learning right here, time taken, and what they were arguing here, the most difficult procedure was epidural anesthesia. It took more replications before they got to 80%. So I think probably what happens here is you get a fixed amount of time to do that procedure, and if you're not successful in that time, and then the anesthesiologist takes over. Some other techniques to do it is a Q-sum method, which is where you really need to look at successes and failures, and you add them up, and you might say that an acceptable failure rate is 10%. This was for total hips, so that 10% fail. That's much higher than you would like in the human side, but might be appropriate for where we are on the veterinary side. And then over time, you look to where you hit steady state. And in this particular episode, I think they hit steady state, they thought, around 44. So what they would argue is if you're a board-certified surgeon, unless you've done 44 total hips, you're still learning. So one question is, should you then be charging the full amount? That's an interesting question. So here's what we've been doing recently, and I'd just like you to introduce this to you. If you look at the time to completion, this was the first time, to my knowledge, this had been done in veterinary medicine. So we modeled this as a cumulative procedure. This was a new surgical technique. It was actually a laparotomy technique in dogs, and you would expect that your time to accomplish that would exponentially decline to reach an asymptote. That's what you would expect, and in fact this modeled beautifully for that. And you can get some complicated nonlinear regression models in there. But effectively, if you look at the 95% confidence interval for the asymptote, which is your standard time, you will see that this takes 9 types of this surgery before you actually hit that asymptotic time. So if we do this for LDA surgery, look at time to completion, this should tell us that we might need 7 LDA surgeries before we can actually say it's competent. So we've got an article in press right now looking at this for about 3,000 sterilization procedures in dogs and cats, and they all model beautifully like this exponential decline down here to an asymptote. And I think this is going to be a very helpful way for defining how many replications you need to ensure that the average person is competent. And then another issue is number performed versus number observed. And then the spacing of repetitions. We've all done these great labs in the 3rd year where the students were really engaged. It was a great learning experience. They all mastered the technique, and an example would be putting a holder on a cow. And then 6 months later, you see that same student out in the clinic, and they've got the holder on backwards. So something happened there. Either that lab originally wasn't as good as you thought it was, or they didn't get enough replications in to actually get it to stick. So it was only in there for a period of time. Very little data on this. We don't really know. And then timing of procedures related to graduation. Quite a few places are actually saying, yes, students can do a venipuncture. It's in their 2nd last year. Yet we're saying that they're competent on graduation. Well, maybe they lost that skill set. So let me have a look here. Very little data on this, but here was very highly trained EMTs, how good at they were running a code blue. So this was a cardiac arrest. So did they follow the protocol? Absolutely. So they were all trained up and they were phenomenal, all at 100%. And this is how good they were 6 months later, 50%. So that probably explains these labs that we do a great job teaching, and then we go ahead and have the students do nothing, and then they actually try and do that 5, 6 months later, and they're only 50% instead of 100%. So we don't know how many times, what is the spacing between all of those events for them to actually get competent. All right, and then there's another issue here about the seasonality of the caseload, and then the caseload varies a lot. For instance, here's an embarrassing fact in the US that nobody wants to talk about. 1/3 of the colleges of veterinary medicine do not cut a left displaced abomasum in the hospital. It's true. So that would be regarded as a routine surgery for dairy. So how are their students therefore competent in dairy? But it's not a criticism of those institutions. They're just in a state that doesn't really have much dairy. They're very strong in beef. So we've got real challenges no matter where we are in the world, in that our caseload is different in different places. But there's also a seasonality, and as you all know, cattle like getting sick in spring. And they really don't get sick much in November, December, January when the weather's really stable. It might be because it's colder and it's a little tougher on pathogens, but that's sort of the way it is worldwide. So that was the in-house data, Illinois. This is production medicine. So if you have the same number of students on in April as you do in December, the ones in December are getting shortchanged. They're not seeing the same caseload. And if it's a seasonal beef or dairy operation, they're probably seeing a completely different type of caseload. So this is another big challenge for us when we're trying to teach ruminant, is to how do we make certain that the students get exposed to everything they need to get exposed to. So what are the areas of emphasis in the core curriculum that I think need to be in there? I think these production medicine people that say it's all about production and we don't care about individual animal, I think they're wrong. I think we've got to emphasize hands-on skills with individual animals. We've got to be competent in that. We've got to deliver on that. We also have to understand animal behavior welfare to be competent in that area. Very standard disease control, prevention, and so on. And all this is covered in the lecture notes. And then in an elective, we can start getting into more of the industry-related things that deal with production and economics and monitoring and reporting and so on. But that's probably, we don't have enough time in the curriculum to deliver that as part of core. So let's move a little bit on. Well, how do we deliver this information? Well, clearly to me, there needs to be different clinical education models depending on local issues. And for most of us, it's going to be driven by geography. So if you're in a major metropolitan area, you're probably not going to get that many animals driven into you. Now, there are some exceptions to that, but usually that makes it a little bit more challenging. Some colleges of veterinary medicine are lucky in that they're in a really livestock dense area. Others aren't. So you sort of have to adjust your teaching to do that. And then it makes a big difference if livestock agriculture is the #1 industry in the state, or is it something that people forget about? So obviously it's an important issue here in Ireland because you had the Minister for Agriculture take time out of his busy schedule to come and open up this conference. But other countries, other states, it's really different. Livestock may not have that much importance. And then I believe that we really should have a professional program and not a vocational school. We should be aligned with the university, and that means we also have to create new knowledge and address societal needs. So there are going to be different clinical education models. To me, you should have a smorgasbord of ways of putting this together. You shouldn't just do one all the time. I think we need clinician educators on site, clinician scientists on site. They might be clinical track or tenure track, however you want to describe those for your university. I think our students need access to practicing veterinarians to see a high volume practice that is out there making a living and how you actually deliver that. And the more repetitions they get to that, they see different personality styles, and then they'll see one personality style is closer to theirs, and that might be a good one for them to model. I think we've got to expose them to general practice and community practice. And then as you get more advanced, I think exposing them to consultants that might be running a 2,000 cow dairy or a 30,000 head feedlot, I think that's very helpful for them to see all the variations that are out there. There might be regional centers of excellence, although this is difficult to pull off. And then I think there's a big place for long distance learning, particularly modules or certificate programs. So the curriculum. So we could do an observational, which is large group, and that's relatively inexpensive. So I've got a couple of slides here that convey this. This is from Hanover in Germany. They do a wonderful job educating their students, and they use different modes, which is what I'm recommending that we all do. So here we have diseased animals coming in. The students are somewhat distant. They have electronic stethoscopes, and the students put the electronic stethoscopes in their ear and they hear the heart murmur and so on. And then they also have different labs, which are small group, where the students are very, very engaged. So you have Professor Rehager here talking to 1 to 2 to 3 students, very, very engaged on surgical procedures. The problem with this is it's expensive. So we really need a mixture of both of these to try and optimize everything. Location. I think it has to be both in-house and ambulatory. I don't think we can deliver a quality food animal program without doing both. And then I think the students also need access to long-distance learning opportunities and continuing ed properties. So I think a teaching hospital is important for in-house teaching. I know this is controversial, but this is why I believe this is something that's needed. This is very well integrated with both education and discovery. So it gives a chance for the faculty to actually continue to create new knowledge, which is an important part of their job. So it's a research lab for the clinical faculty. And then from a university perspective, that is certainly something that can help grow collaborative, interdisciplinary, and translational research. Some of the other advantages are we can see the evolution of disease process. So you can see what an off-feed cow looks like and what they look like when they start eating or what they look like when they haven't eaten for 5 days and they're just melting away in front of you. We can certainly get more students to look at the animals. We've got more time and we've got better facilities. Typically they're on some farms, which can be dangerous for people to work at. So the disadvantages are that we're not seeing this individual animal as part of a production system. So we're missing out on a lot of great learning that needs to be there. So the students don't get an understanding about the importance of environment and management on the disease. And it's also expensive to do that. The other challenge, and this is particularly in Europe, that's driven a lot of decisions to shut, like Utrecht is shut for haul in, haul out in hospital caseload because of concerns about biosecurity. So I think that this can be managed. I think it's being managed well at a number of places in Europe, that we can deliver a biosecure environment for most of these diseases. Obviously, foot and mouth got going, that would be a different system. So ambulatory, some of the real advantages there are real world conditions and economics, and again, the population. So I'm running a little bit out of time here. I just want to get through some other techniques. I will tell you that if you align your in-house case faculty based on discipline, you will have a much lower food animal caseload than you will if you align it on species. So if we want a vibrant food animal caseload, our hospital should be based on food animal medicine and surgery and maybe reproduction, and not large animal surgery, large animal medicine. If you go large animal medicine, large animal surgery, you can pretty much say goodbye to your food animal caseload. So we've got a paper on that to go with. So a couple of other things I just wanted to finish up with is on specialization. So I think the way it was done in North America followed human medicine specialization. I think it's been an abject failure for food animal medicine. So the model there is you're a discipline specialist in anesthesiology, and then you apply that to different species. I'm a board certified in 2 areas, but I just don't think that this works for specialization for food animal. So what I think does work is the European model with the European College of Bovine Health Management. What they've said is, first off, you're a card-carrying cattle guy. That's who you are. And then you subspecialize within that. And I think this way our specialization is much better aligned with the industry. We understand the industry, we understand the economics, we can talk the talk when we're talking to clients, rather than have someone who really only talks to a cattle client once every 2 years and they really like eyeballs. Well, that might be great for an eyeball, but we're usually treating more than an eyeball. So the other things that I think will be happening is certificate programs and continuing education modules and conferences just like this, but I think there'll be more focused continuing education model, let's say on embryo transfer in cattle. It might be on breeding soundness. It might be on advanced training in abdominal surgery in dairy cattle, if you like. But another thing is certificate programs. Very proud to say University of Illinois has been the leader in North America on these. For 25 years we've been delivering these postgraduate certificate programs, which are 10 separate visits of 2 days over 2 years with your peers around the country. So it's a chance to heavily network with about 40 other people that are industry leaders. They cover important things for the industry, such as global marketing or biosecurity or residue issues or so on. And these have been exceptionally well received at the University of Illinois, and we're about to do our first one related with beef cattle in partnership with Kansas State University. So there's more details on that with our website. And then the last one are these MOOCs, which is massive open online courses. And Dr. Aldrich and Dr. Lowe at the University of Illinois have done this wonderful MOOC. You can get a list of ones that are available there relative to veterinary medicine. Here is the one that Dr. Aldrich and Dr. Lowe did related with sustainable food production through livestock health management. These can be free, but if you want a certificate, then you have to pay some money but that makes you more marketable in the marketplace. You might be able to then command a higher salary, or you might be able to get clients to pay you more money. So with that, I would like to thank you for your attention. I spoke very quickly because this wasn't being translated, and I figured that most of the people here would understand my hybrid Australian-American accent, and I thank you very much for your attention.
Thank you, Dr. Constable. And for those of you who'd like to ask any questions, we've got a few minutes. Certainly. Yeah, David.
Kerstin
If you can wait till the microphone gets to you, that'd be fantastic. All right, we'll start up there. Yeah, that'd be great. Thank you.
Kerstin Müller from Berlin Free University. Thank you very much for your solidarity for individual animal medicine. So it's wonderful to hear it. But I have a question. Quality has one definition, which is fulfills the expectations of the client. So shouldn't we ask the client what he expects from the veterinarian? Should we ask the people what they have always done? Does this fulfill the expectations of the client?
I think you raise a very good question there. The client pays the bills for private practice, but do they have the adequate knowledge to be able to evaluate excellence of performance? Sometimes they make a judgment call on one thing. It might have been a very difficult case, might have been an unusual case. But what I think what you're really getting at is that we need to meet societal needs. But we can't afford to get everyone to be a specialist with their first DVM degree. So I think there's different levels. We can have a competent entry-level veterinarian, but what your client might be asking for is someone that's more than that, in which case those veterinarians, after they graduate, need to go ahead and continue to learn. And I like the statement that a veterinary degree is not a license to practice, it's a license to learn. So really, we're looking at lifelong learning, and these modules might be one way of actually helping get to your client. So maybe you get a certificate in mastitis. So if the client really has some demands about a mastitis problem, maybe they then seek out a veterinarian in a practice that has documented expertise, postgraduate with mastitis.
Thank you.
Thank you for your presentation, Peter Constable. Ruud Jorisma, Utrecht University. I have, again, a little bit of a follow-up on the question of Kerstin Müller, and that is about how you define your curriculum based on what is currently done. Isn't it a big risk that if you do it like that, that the progress of the discipline is not that fast as you probably would like it to have? Wouldn't it be better to also have a kind of a future idea, or what you expect would be the job of the veterinary in the future? Yeah. And related to that, I was quite a little bit surprised that your emphasis on skills, on practical skills, was that much compared to the analytical skills, which are in particular at the herd level, I think, very important for farm animal practitioners.
So I agree with you. I mean, one of the roles of faculty is to be able to anticipate what are the future skills needed of entry-level veterinarians. But what I have found is that quite a few of the faculty haven't been out in practice, or haven't been out in practice for quite a while, and then we all get excited about our own little focus area, and we're not really spending the amount of time, and castration was a great example for us in our curriculum, is we're not expending the amount of time that we really should be on that area. So to get to, I think, your second question on analytical skills, to me that is a higher level integration synthesis part, that's a higher level of learning. That is what we should aspire for our veterinarians, but we can't afford to get them, every student there in a 4-year DVM degree, when they're also meant to be competent in dogs and cats. So if you really want to go in that direction, I think we're going to have to start talking about limited licensure, and you just forget them learning about dogs and cats. And then I think you have a chance of getting that. But the state boards are really going to be dictating when that happens, and I think it's a long way off in really happen. So what I think is happening now is that we're going to have to do more of these postgraduate certificates to document competency in production skills, in how to really look at herd production data and which are the real critical ones and which is just a divider of something else. But is that a competent entry-level skill? All of the data that I've seen, no. The producers, it's not being done out in practice commonly. And if you talk to most people that have done that, they sort of get frustrated because they still can't do enough of that they would like. They're still doing a lot of the routine things unless they're in a large practice and they've been able to build up a clientele over a larger geographic area.
Thank you very much. My apologies. We're going to have to cut the questioning short. I know it's a great topic. So you feel free to talk to Dean Constable afterwards. We finish this session at 4 o'clock, so he'll be around as well at that time. Thank you very much, Dean Constable.